So I start with the common one, the heart failure with reduced ejection fraction. So this is an example of a patient. He's a 56 years old man who is a banker, and he has established cardiovascular disease. He had undergone a bypass surgery about 4 years ago. He presented in the emergency department, essentially with acute onset of shortness of breath. And when you take the history, he has been having autopnic for the past couple of weeks. And he also noticed the presence of leg swelling for the past couple of weeks also. So you actually have symptoms of heart failure. When you examine the patient, as expected, the patient has basal crepitation on the lung examination, and he also has bilateral ankle edema. So this is the echo. As you can see here, you definitely see reduced ejection fraction, and the report came back as LVEF around 25%. So this is how you diagnose HFrEF, where your patient presented with symptoms and signs, ejection fraction is less than 40%. So the question to you is, what medicine will you start? Right? Essentially, if you actually have access to all this medicine, you would like to start all this medication. In fact, if you actually look at the last ESC guideline in 2016, so the first line is always ACE inhibitor and the beta blocker. If the patient is still symptomatic, then you actually add MRA or spironolactone. So this is the standard therapy. ACE inhibitor, beta blocker, and then mineralocorticoid antagonist. Then if the patient is actually continuing to be symptomatic, then you will consider ANI, or you may consider ivabradine. Again, this is the standard therapy. Based on the most recent heart failure trial, which is a paradigm heart failure trial, looking at heart failure with reduced ejection fraction, you can see that the ANI is actually better than ACE inhibitor. So a lot of guidelines have changed. A lot of guidelines have changed in the sense that they actually put ANI or sacubitril/valsartan as the first line. One example is the Malaysian guideline, where we actually put ANI as the first line instead of ACE inhibitor or ARB if the hospital can afford, if patient can afford. So this is the latest guideline as far as HFrEF or reduced ejection fraction is concerned. Now, if you actually look back all the medication that we have, the ACE inhibitor, the ANI, the beta blocker, you can summarize it, all these medications that actually work on two main systems. The first system, the renal angiotensin system. Example will be ACE inhibitor, ARB, ANI, or MRA. Of course, the other system works on the sympathetic system, the beta blocker, and the ivabradine. So this is what we know about HFrEF. This is what you and I using to treat patient, and this is what you and I teaching the student. Now you have two pathogenesis of heart failure where you actually have RAS system problem and sympathetic problem. So this is true. This is what we teach. Unfortunately, things change when we actually have EMBARAC study. You all have seen the main result of EMBARAC study, that the cardiovascular death, the non-fatal MI, and non-fatal stroke has been reduced with empagliflozin. But there's another result that actually surprised us, that is the hospitalization for heart failure. This is a diabetic drug, and yet it actually reduced hospitalization for heart failure, and it actually very fast. Within a couple of weeks, you actually see reduction of hospitalization of heart failure. This is definitely not a result of sugar lowering. The medicine have shown important, the medicine have shown significant reduction of heart failure hospitalization. And this is true across all the SGLT2 inhibitors, whether it's empagliflozin, canagliflozin, or dapagliflozin, they show the same result. All these SGLT2 reduce hospitalization for heart failure. This is unexpected result because it doesn't fulfill, SGLT2 does not work on the renal angiotensin system, it does not work on the sympathetic system. So all these results actually change the guideline. Prof. Chan has shown you this is the latest guideline, but I'm just going to highlight this part of the high-risk patient. So this is what is changed, right? Established coronary artery disease, established cardiovascular disease. You also have a portion that actually looking at heart failure and renal impairment. What I want you to see, the updated one, essentially number one, now we actually have specific criteria for you to start SGLT2 because of the clinical trial result that was presented by Prof. Chan and what we see on the hospitalization for heart failure. So this is a different to 2019 standard of care, and this is the latest 2020 standard of care based on ADA updates. So you can see now they are very specific which group are considered high risk of hospital heart failure. So these are the criteria now, the CKT and the heart failure. And we prefer you to start on SGLT2 inhibitors in the presence of kidney impairment, in the presence of HFrEF or heart failure with reduced ejection fraction. So come back to our patient. This patient have two problems. He have established cardiovascular disease because of the previous bypass. He also have heart failure, HFrEF because of EF of about 25% presenting with heart failure. So in this patient, this will be the best medication that I would like to use. I will select empagliflozin for two main reasons. Number one, it has been shown in clinical trial to reduce cardiac death. Number two, empagliflozin also has been shown to have reduced hospitalization for heart failure. So this is the benefit again, looking at hospitalization for heart failure is a class effect where across all the SGLT2 inhibitors. But as far as cardiac death is concerned, only empagliflozin has been shown in clinical trial among these high-risk patients to reduce cardiac death. That is the reason of the selection of empagliflozin in this patient. What if I remove the diabetic? This patient is not diabetic. This patient have bypass. This patient have heart failure. Will SGLT2 work based on all the trial we have seen? So this is actually answered by DAPA heart failure DAPA heart failure trial, where they actually recruit patients with diabetic and non-diabetic, ejection fraction less than 40%, symptomatic failure, and the biomarkers is actually elevated. On one arm, they're giving dapagliflozin and SGLT2. On the other arm, they are looking at placebo. This is not a CVOT trial. This is not a diabetic CVOT trial that Prof. Chan has shown you. This is a heart failure trial. They recruit patients with heart failure and they use SGLT2 to compare with the standard of care. The result actually is positive. Using SGLT2 inhibitors among heart failure patients, as you can see here in the blue color line versus the placebo and red color line, you actually have shown dapagliflozin reduced cardiovascular death, hospitalization for heart failure, and urgent visit to the hospital. So dapagliflozin reduced all these primary endpoints, and as you can see, it's similar to EMPA-REG study where the difference occurs very early in time. If you just focus on the hospitalization of heart failure in DAPA-HF, again you see the same thing. Very early on, the graph separate and a very significant p-value has a relative risk reduction of about 30%. It works whether they have diabetes or not diabetes. As you can see here, majority of the patients in the DAPA heart failure study are actually non-diabetic. Nearly 59% of the patients are actually non-diabetes, and yet, as you can see here, the benefit just as good as the patient who is a diabetic. So in other words, dapagliflozin, based on DAPA heart failure trial, have shown benefit among patients with heart failure. Of course, the question that you have for me is, to a patient who is not diabetic getting more severe hypoglycemic? Answer is no. If you actually look at all these major side effects, major hypoglycemic and diabetic ketoacidosis, again, you can see that this adverse event is actually not significant. In other words, although we think, and it still is, SGLT2 is a diabetic drug, but when you give this medication to patients with heart failure, even among patients who is non-diabetes, it does not show increase of hypoglycemic, it does not show increase in diabetic ketoacidosis. Right? So, come back to all this clinical trial with SGLT2 in heart failure. What type of heart failure trial is a heart failure trial? We looked, these are the various heart failure trials using SGLT2. I'm just putting the saroglitazone as a comparison. So these are the trials. TABA heart failure has been published, empagliflozin is ongoing with Emperor heart failure study. These are the primary endpoints, and this is the result. Right? We expect the result of empagliflozin in heart failure end of next year. Then we should know what is the impact of empagliflozin in the setting of heart failure. This is endpoint study. This is endpoint study. In other words, we know SGLT2 works for heart failure. We know dapagliflozin reduces hospitalization for heart failure, so it is positive. The question now is how? How does it work? How does SGLT2 reduce hospitalization? What mechanism is it? Right? So we know it works. Now we want to know how it works. So there are various studies looking at and want to try to find out how it works. So number one, so there's various studies looking at biomarkers, impact of biomarker, impact of symptoms, quality of life. There are studies looking at 6-minute walk test. There are studies even looking at MRI, what is the impact of MRI, what is the impact of SGLT on echo parameters in all these various studies. Again, we know it works. We know SGLT2 reduce hospitalization for heart failure as a class, but how does it work? Right? So we actually have a publication. This is published a few months ago. So this is define heart failure. We try to define how SGLT2 works. So the same group of patients like TABA heart failure, same trial design, same dosage, but now the primary endpoint is no more cardiovascular death, hospitalization of heart failure, no more. We are looking at 6-minute walk test, we are looking at biomarkers, we are looking at symptom score. So the result, this is symptom scoring. So again, you can see that in red, orange color, dapagliflozin actually improved the symptom score among patients with heart failure. It improved the quality of life among patients with heart failure. So the symptom score improved, the quality of life score improved. But it does not change the biomarkers of heart failure. Does not reduce the biomarkers of heart failure, namely pro-BNP. So as you can see here, dapagliflozin have no significant reduction of biomarkers compared with standard therapy. It also does not change 6-minute walk test. The patient did not walk further after dapagliflozin compared with placebo. So this is again confirmed by recent announcement of Emperor study of 6-minute walk test with empagliflozin, again show no improvement in 6-minute walk test. So this is now what we know about SGLT2. We know it from dapagliflozin study defined. We also know it from announcement about Emperor. So this is the current status. We know it improves the symptoms. We know that it improves the quality of life, but no impact of biomarkers, no impact on 6-minute walk test. This is in big contrast with paradigm study. It reduced significantly all the biomarkers of the heart failure using sacubitril valsartan. It also improved the 6-minute walk test. So I think this works differently from the rest of the heart failure medicine. SGLT2 works differently from what we already know that I have shown you just now. I think it does not work just like RAS system medication. It does not work just like sympathetic system. It does reduce outcome, it does reduce cardiac death, it does reduce hospitalization, but it do not reduce biomarkers, it does not improve 6-minute walk test. I think there might be another pathway in heart failure. I think there may be another pathway in the pathogenesis of heart failure. This might be a new pathogenesis pathway for us to treat heart failure patients. And I think DAPA heart failure has shown us that it works. We just do not know how it works. I'll move on quickly on heart failure with preserved ejection fraction. So this is 67 years of age, hypertension for 10 years, non-diabetic. Again, presents similarly like my first patient with acute shortness of breath and bilateral angioedema. Blood pressure is slightly on the high side with systolic 150. He also has signs of heart failure with bibasal crepitation and bilateral angioedema. Chest X-ray does show acute pulmonary edema and biomarkers is also raised. So this is an echo. So you can see that the muscle is thickened, but the ejection fraction is normal. So this is how you diagnose heart failure with preserved ejection fraction. You need to have symptoms and signs. You need to have normal echo. You need to have elevated biomarkers and with other signs of echosonography pictures. Right, so this is how we diagnose HFpEF. It's actually a common problem. A lot of us felt that HFpEF is not common. A lot of us felt that HFpEF is actually not common, but if you actually look at this clinical trial, we are going to see more and more HFpEF. In fact, 60% of the hospital admission in my hospital with heart failure are with normal ejection fraction. So you're going to get to see more and more, right? Treatment? Nothing. The most simple slide of all. Nothing. There's no algorithm for as far as treatment is concerned. Zero. Have we done clinical trials on HFpEF? Long list. We have tried all sorts of medication. We have tried things like ACE inhibitor, beta blocker, digoxin, sildenafil, ivermectin, right? And if you actually look at all the results, everything is neutral. The most recent trial is Paragon heart failure, recently. Essentially, this is using sacubitril valsartan versus the standard of care in patients with HFpEF, preserved ejection fraction, and the result essentially are no difference compared with standard therapy. Right? So until now, we do not have any medication that actually change the outcome of patients with HFpEF. Right? We have tried all the medication that you and I use for HFrEF. None of it actually show good result as in a HFrEF. Right? So come back to our patient. We diagnose HFpEF. So my question to you is how to treat. He presents with heart failure, so does have a problem. So how are we going to treat? Now we do not actually have good medication for HFpEF. So the answer is still the same thing what you and I do. Blood pressure control, advise the patient to weight reduction, advise the patient to have lifestyle changes. So this is what you and I do. Alright? But if you actually look at this, my question to you is, do we bother to look for a medicine for HFpEF as long as we just treat the risk factor? isn't it? We treat their hypertension, we ask them to cut down the body weight. That's enough really, but why we need a medication for HFpEF? The reason is because HFpEF does have more mortality risk compared with just a simple hypertension. The red color is diabetes, the blue color are all hypertension, and this green color are patients with HFpEF. As you can see here, if you think that just treating a HFpEF like hypertension is wrong, because they actually have higher mortality rate compared with just simple hypertension. In fact, if you actually go and look through all the all-cause mortality in various diseases, atrial fibrillation, diabetic with established cardiovascular disease, and heart failure. So these are the all-cause mortality across all these serious disorders. If you look at the Paragon heart failure study, the most recent trial of HFpEF, the mortality rate is actually pretty high. The mortality rate is actually pretty high, and it's actually higher than MBARAC, is higher than patient with atrial fibrillation. So it's a common problem. It does have high mortality. It's just that we do not know how to treat. And so there is a lot of SGLT2 trial looking at heart failure with preserved ejection fraction. Some of it hopefully will be announced next year. So these are the various studies that we are looking for to see whether it will change how you and I manage a patient like I present to you just now. We have the outcome study. We also have mechanistic study to see how it works among heart failure with preserved ejection fraction. Hopefully, if these results are positive, it will sort of help us to understand HFpEF more in the future. So ladies and gentlemen, in summary, I think now we actually sort of define heart failure very tightly in various kind of heart failure. Mid-range is new, we do not know how to treat, but the reduced ejection fraction and preserved ejection fraction are the one we are very commonly seen in the daily practice. We learned from all these CVOT trials that SGLT2 reduce hospitalization for heart failure, so they actually have trials such as STARBA heart failure and EMPEROR study to look at these primary outcomes. And it works whether you are diabetic or whether the patient is a non-diabetic. It has been shown the result is that it does reduce all these primary endpoints. So it works, but we don't know how it works. So these are the mechanistic study. So the result actually so far, it works in improving the symptoms and quality of life, but SGLT2 does not reduce biomarkers. SGLT2 does not improve the 6-minute walk test. So we do not know how it works, right? I think that is maybe another pathway in the pathogenesis of heart failure that hopefully SGLT2 will be able to tell us where to go, and hopefully this will change our outlook of our patient with heart failure. So this is the current status of the preserved ejection fraction. We do not have good treatment, so hopefully all this trial with SGLT2 will tell us how we are going forward in the treatment of HFpEF. Right, with that, thank you very much.